The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Getting Past the Blood-Brain Barrier in Brain Tumor Treatment. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. James Liu is a neurosurgeon who specializes in the surgical and radiosurgical treatment of brain and spine tumors. Currently, he is an assistant member in the Department of Neuro-Oncology at Moffitt Cancer Center and assistant professor of oncologic sciences at the University of South Florida. He also leads a laboratory research effort focused on understanding the molecular mechanisms that drive the formation of brain tumors. In particular, the Liu Laboratory focuses on how a subset of the tumor population with tumor initiating or stem-like properties contribute to the proliferation of brain tumors and the resistance to medical therapies. Thank you so much for joining us, Dr. Liu. You may now begin your presentation.
Good afternoon, everybody. Thank you for joining us. And thank you, Umbreen, for inviting me. And thank you to the American Brain Tumor Association for hosting this webinar. Today, I have the privilege of talking to you about the blood-brain barrier and how it affects brain tumor treatment. I have no disclosures that are pertinent. Now, to start, I want to talk a little bit about the outline of the presentation, and I'm going to break it up into two parts. The first part, we're going to talk a little bit about the background of the blood-brain barrier, what it is, its function, and how it plays a role in how cancer travels to the brain. The second part of this talk, we'll talk about the clinical implications of the blood-brain barrier, and particularly the challenges that the blood-brain barrier poses for us when we try to treat brain tumors, and also talk about some of the strategies that we have developed to try to overcome this barrier for the delivery of brain tumor therapeutics. So part one. To start, we'll talk a little bit about the background of the blood-brain barrier and what it is. So to start, the blood-brain barrier is a very unique structure that's considered a neurovascular unit within the brain that serves as a gatekeeper of the central nervous system. It mediates the exchange, transport, and clearance of solutes between the brain and the peripheral vasculature. It provides a stable environment for neural function by preventing the entry of toxic proteins into the nervous system. It does so through several ways, which we'll talk about, but in particular, it prevents the passage of certain compounds into the brain through the formation of tight junctions, which are present in between the cells. It also allows select nutrients and metabolites to pass through the brain through various transport systems. To understand how the blood-brain barrier functions, we have to understand the components that make up the blood-brain barrier. Essentially, the blood-brain barrier is composed of a few very important cells: the endothelial cells, astrocytes, pericytes, the basement membrane which surround these cells, as well as other supporting neural cells such as glia and neurons. The endothelial cells, one of the most important players of the blood-brain barrier, are connected together by tight junctions and adherens junctions, which hold the cells together, giving the tissue structural support, and also are very important and preventing leaking passage of structures in between the cells. Brain endothelial cells in particular are unique in some ways because they have pinocyte vesicles that allow, and as well as greater concentration of mitochondria. Mitochondria are a component of the cells that are involved in producing energy, which implicates how important brain endothelial cells are in delivering things back and forth between the endothelial cells into the brain and out of the brain. The control of passage of molecules by the endothelial cells are also regulated by an enzymatic surveillance system, which basically means that there are enzymes that help to function and monitor what goes through the brain and the endothelial cells. Now, taking a closer look at the blood-brain barrier and the structures that make it up, on the left side is a wider view of the blood-brain barrier. Here you can see in the center is the blood vessel, the capillary where the blood runs through. The first barrier that surrounds the blood vessel is the endothelial cell. And these endothelial cells are held together by tight junctions, so there's not an opening to allow free passage of material. On top of the endothelial cells are pericytes, which are structural cells that support the endothelial cells and work in very close conjunction with endothelial cells. Around them are the astrocytes, which are a type of neural cells, actually the most common type of cell in the brain. Together, these create a basal lamina or a basement membrane that surround the cells and also contribute to the blood-brain barrier. And here in a magnified view, you can see the endothelial cells together connected together by tight junctions, astrocytes, as well as pericytes, which are support cells that communicate with the endothelial cells, as well as neurons that are present in the brain that also communicate with the astrocytes, pericytes, and the endothelial cells. Microglia are also other support cells, similar to immune cells that are present in the brain that can function with these cells and also contribute to the overall characteristic of the blood-brain blood-brain barrier. Now, after having understood what makes up the blood-brain barrier, we have to understand how it regulates certain types of transport across for its functioning. Now, there are several types of transport mechanisms across the blood-brain barrier. The first is what's called the paracellular aqueous pathway. This is a pathway of structures when proteins pass through the cells, in between the cells, through the spaces that connect the cells. As we talked about before, these spaces are connected together by tight junctions, and these junctions can prevent the passage of certain types of material through the cells. Typically, the only types of material that can pass through these tight junctions are water-soluble agents, which means agents that can dissolve in water and are typically pretty small. And so this is a pretty select way for passage of material from the vasculature into the brain. Another type of passage mechanism is through the cell. And this is typically reserved for small molecules that are lipid soluble, which means they're soluble in fat. So they can dissolve into fat, and which allows them to pass through the cell wall from one side into the other. Being that they are only allowed for very small molecules and that they have to be lipid soluble, that limits the passage of certain types of material. Another way for things to pass through the cell is through transport proteins. These are proteins on the surface of the cell that are specifically made to transport certain types of molecules, such as glucose or amino acids or other molecules. They bind to these molecules and they specifically transport them across the cell safely. So although this allows for transport across the endothelial cell and across the blood-brain barrier, it has to be specific for the type of cell it's transporting. Now, the final type of transport across the blood-brain barrier is transcytosis. Now, transcytosis means it takes structures that want to pass through the endothelial cells and it engulfs them into a vesicle, and it travels through the endothelial cell and then releases the product into the brain. The vesicles allow protection of these materials so they're not digested within the cell. There are two types of transcytosis that occurs within the endothelial cells. One is receptor-mediated transcytosis, in which molecules bind to certain receptors that are specific for these molecules, and then they allow for the transcytosis of these structures. Another is called adsorptive transcytosis, in which these molecules develop a positive charge on their surface, and upon hitting the cell surface, they are engulfed in these vesicles and transported across. Now, having talked about the four main mechanisms of transport across the blood-brain barrier, we also have to talk about one other transport mechanism that's not specifically meant for transporting things from the vascular side into the brain, but the other way around. These are called blood-brain barrier efflux transporters. Now, in particular, there's one main one called the ATP binding cassette transporter, or the ABC transporters. Now, unlike the other transporters that we just talked about that primarily deliver things from the blood vessels into the brain, these are a family of proteins whose main role is to actively efflux and pump metabolites from the brain back into the vasculature. So they remove things from the brain. Their main goal for doing so is to protect the brain from potentially neurotoxic molecules. These transporters have a high affinity for lipid soluble molecules, which are molecules that can dissolve in fat. There are several types of these transporters. In particular, there's the MDRP, or the multi-drug resistant protein, as well as the BCRP, or the breast cancer resistance protein, which are associated with high rates of drug resistance when delivering drugs to treat certain types of cancers. And you can see here on the brain side, these cells specifically, these transports specifically transport molecules out of the brain and back into the blood. The blood-brain barrier's function can be disrupted through certain types of diseases. In particular, the blood-brain barrier can malfunction in multiple sclerosis, in the presence of hypoxia or ischemia, or essentially stroke, as well as in Parkinson's disease, Alzheimer's disease, epilepsy, glaucoma, lysosomal storage disease, which is a type of malfunction within the cell. And most importantly for us, it can also disrupt in tumors. Within tumors, the blood-brain barrier has a different conformation and is really known as the blood-tumor barrier because the tumor manipulates the way the blood-brain barrier is formed and the structures of the blood-brain barrier to have a unique structure that's slightly different from a natural blood-brain barrier. The blood-tumor barrier is generally leakier than the blood-brain barrier because it's characterized by aberrant parasite distribution and loss of astrocytic end feet and neuronal connections. Essentially what that means is that the parasites and the astrocytes would make up the blood-brain barrier are disrupted by the tumors and they don't function properly. And so they cause greater permeability of the blood-brain barrier. There's also increase in immune cells within the blood-brain barrier, or within the brain, due to loss of the blood-brain barrier integrity. Despite this permeability, this increased permeability of the blood-brain barrier from the tumor affecting it, there's still the maintaining of the efflux transporters that we talked about. So certain types of anti-cancer agents can still be pumped out of the brain and prevent us from delivering proper therapeutics into the brain. Now that we have established what creates the blood-brain barrier and its function, I'd like to talk a little bit about how cancer travels to the brain and how the blood-brain barrier plays a role in this. Now, this requires talking about the origin of brain metastasis, because when we talk about cancer traveling to the brain, we're primarily talking about brain metastasis, or cancer cells from other parts of the body, like the lung or the liver or the breast, that travels to the brain. And so this primarily includes brain metastasis. Now, with the advancements of systemic cancers and allowing us to treat systemic cancers better, there's actually been a higher incidence of brain metastasis because as people have lived longer, patients have lived longer, there have been more of an opportunity for brain metastasis to pop up. And so we have seen more prevalence of brain metastasis as we've improved our systemic cancer treatments. Now, the most common type of metastatic brain tumors originate from cancers of lung, breast, skin, or melanoma, the kidney, as well as the gastrointestinal tract. Cancers from other sites can also go to the brain, but these are primarily the main ones. Now, metastasis occurs when a tumor cell from the original cancer or the parental tumor sheds from the primary tumor with the ability to establish a metastatic tumor at a secondary site. And this secondary site for us would be the brain. But this is actually a very rare occurrence because it's estimated that only 0.01 to 0.02 of cells that shed from the parental tumor are actually able to metastasize to a distant organ. So a lot of work has been focused on how this occurs and what is the process that allows a cell to shed from a parental tumor and colonize in the brain. And so there's a lot of talk about how this occurs and theories and research that goes on to it, but essentially it's really about survival of the fittest. And the concept of metastasis is that it occurs as a result of a combination of anatomical, mechanical, and biological factors. And there have been a lot of theories over the years to try to explain how metastasis occurs. One of these theories is the mechanical hypothesis, in which that metastatic tumors develop purely from a mechanical standpoint, in that the tumor goes into the blood vessel, and the first place it gets stuck at, because of a small blood vessel, is where it goes to the tumor. It develops a tumor. There is the cancer stem cell hypothesis, in which that a small fraction of tumor cells are considered stem cells, and they're able to initiate tumors. So when these small fraction of cells go to another spot, they can grow tumors, but not other cells that don't have stem cell features. Another theory is the epithelial mesenchymal transition. In this hypothesis, it states that the cells undergo a reversible process where the parental tumor cells convert to a metastasis-forming state, which allows them to travel to a secondary site through the blood vessels. And then once they're at the secondary site, they convert back to a tumor forming state. And so they have multiple types of characteristics which they take on to allow either tumor growth or traveling throughout the body. And then there's the thought of that tumor metastasis occurs through hematogenous dissemination, in which tumor cells secrete proteolytic enzymes that break down the basement membrane of the epithelial cells to allow them to enter into the blood vessel. And then once they're in the blood vessels, they travel in the bloodstream and they go to a distant organ and create a tumor. As you can see here, these theories are not necessarily exclusive of one another. Likely what's going on is a combination of all of these things that are happening and allowing the tumor cell to leave its parental site and go to a different site. And so to summarize the idea of metastasis, we'll start with a primary tumor in one spot, whether it's the lung or the breast or somewhere else in the body. The tumor grows. In order for the tumor to go to a different site, it has to create vasculature, it has to proliferate, it has to grow, and then it detaches from the parental tumor and it goes into the circulation and it travels in the blood vessels. And then it travels along the blood vessels and it decides in a certain organ it's going to stop. It could be another organ like the lung or the liver, or in our case would be the brain. But once it gets to the brain, it has to adhere to the wall and it has to leave the blood vessel and then go into the structure. And so for us, this involves the tumor cell leaving and passing through the endothelial cell and the blood-brain barrier and going out into the brain. And then once it's in the brain, it doesn't necessarily create a tumor. There has to be the right combination of things that occur that allows for the tumor to grow and for a tumor to develop that we can see. And so this is a combination of all those hypotheses that I spoke about. But one particular hypothesis that actually was coined a long time ago really summarizes the idea of what results in metastasis. So this is called the seed in the soil hypothesis. So in 1889, a long time ago, before all those other hypotheses that I mentioned, Stephen Paget, who was a British surgeon, suggested that metastatic tumors created depended on the interaction between the tumor cell, which he considered the seed, and the target organ, which he considered the soil. And he determined, in his words, that when a plant goes to seed, its seeds are carried in all directions, but they can only live and grow if they fall on congenial soil. Now, the idea is that it doesn't matter if the tumor cell just lands in a spot. It has to be the right spot where the tumor cell and the soil communicate with one another, and it provides an environment which allows the tumor cell to grow into a tumor or a metastatic tumor. And so he emphasized the importance of this interaction between the cell and the organ in which it's going to. And this, it helps to explain why you don't have metastasis everywhere, and that the actual rate of metastasis is relatively low because it has to be this perfect combination between the tumor cell and the soil. And he determined that there were three main principles for the development of metastatic tumors. The tumor, one is that the tumor is composed of a heterogeneous cell population within different traits, that not all tumor cells are created equal, that only certain tumor cells have the trait to leave and create metastatic tumors. The second principle is that the specific tumor cells have the characteristic to develop metastases in certain areas. And the third principle is that the formation of these secondary tumors depend on the interaction between the tumor cell and their new environment. So how do tumor cells invade the brain? Once these cells that are able to metastasize go into the blood vessels, they have to penetrate the blood-brain barrier, which we just finished talking about is very non-permeable and is designed to keep things that we don't want out of the brain. So why do tumor cells invade the brain? Well, these cells, once they go into the blood vessels, we call them circulating tumor cells. They arrest at the level of the capillaries in the target organ, which is the brain in our case. These circulating tumor cells need longer time to extravasate into the brain than other organs. It's actually been shown that for lung cancer cells, it takes 2 days for the cells to leave the blood vessels. And for breast cancer cells, it can take for 2 to 7 days to leave the blood vessels. And the need to survive longer within the brain vasculature may be a limiting step for achieving metastasis. This means that even though these cancer cells can go to the brain, they have to be certain types of cancer cells that allow them to live long enough so that they can extravasate out of the blood vessels and then go into the brain. And the way they do this is that they interact with the blood-brain barrier and the endothelial cells in a specific way that allows them to leave the vasculature. There's been research that's demonstrated that there's a crosstalk between the circulating tumor cells and the endothelial cells that make up the blood-brain barrier that may actually manipulate the shape of the tumor to assist its migration across the blood-brain barrier. There's also been work that's shown that astrocytes, which are part of the blood-brain barrier, may interact with the tumor cells and allow for certain enzymes to be secreted that degrade the blood-brain barrier and actually facilitate transport of the tumor cells. So despite the blood-brain barrier's function to keep toxic things out, they interact actually in a positive way with certain types of tumor cells, which facilitate the development of metastatic tumors. In addition, circulating tumor cells can be taken up by the endothelial cells through these endocytosis or these vesicles and transported across the brain because they're mistaken for things that they should be transported as opposed to being injected out of the endothelial cells and back into the vasculature. This is just a summary of a couple of ways in which tumor cells can cross over the blood-brain barrier and enter into the brain. The paracellular pathway, which is in between the cells, can occur because the tumor cells can secrete certain types of enzymes that destroy the tight junctions, which are important in blocking transport of material in between the cells. The tumor cells can destroy these tight junctions and they can flow in between the cells. The other method is the transcellular pathway, in which the tumor cells can bind to certain receptors present on the cells and essentially trick the cells into transporting the tumor cells across. This also involves morphing of the tumor cells in a way that allows for transport of the tumor cells into the brain. And so in this sense, the blood-brain barrier can actually work with these tumor cells as opposed to keeping them away. And so a lot of work has been done to try to understand how we can stop this interaction and prevent the blood-brain barrier from allowing these cells to come into the brain. Now, to summarize the first part of the talk, the blood-brain barrier is a neurovascular unit composed of numerous types of cells that are held together by special junctions to form a selective barrier between the brain and the vasculature. There are several mechanisms that allow for transport of solutes across the blood-brain barrier, but these are very selective and may be counteracted by the presence of efflux pumps. Metastatic tumors form likely as a result of a combination of factors, but most importantly, it's the interaction between the circulating tumor cell and the target microenvironment, and thus the seed in the soil hypothesis. So now we come to the second part of our talk, which is really like a clinical implications of the blood-brain barrier. The first part of this, we'll talk about the blood-brain barrier and how it affects therapeutic resistance, meaning how it affects our ability to deliver drugs to brain tumors. Now, when we think about delivering drugs to brain tumors and the barriers, the blood-brain barrier is a natural barrier to allowing drugs to pass into the brain. That's its main job, and it prevents the passage of certain large water-soluble molecules because, as we mentioned before, for passage of certain things in between the cells, they have to be small and they have to be water-soluble. Drug penetration is inhibited in the brain by three main factors. One is the blood-brain barrier, but there are other things that after it passes through the blood-brain barrier that also inhibits drug penetration. And this includes the extracellular space, the space in around the cells in the brain that are related to the brain tumor penetration barrier. There's also genetic heterogeneity and instability that's related to the treatment efficacy barrier that enables the development of treatment-resistant cells. But primarily, we're going to focus on the blood-brain barrier and how it doesn't allow for drugs to adequately penetrate from the blood vessels into the brain. There are also active transporters, as we talked about, these efflux transporters that also prevent entry of drugs, or they efflux transport drugs that pass into the brain back into the vasculature, which presents a hindrance to delivery of drugs into the brain. Because of all these barriers to therapeutics, a research study that showed in the database of over 7,000 drugs, very few drugs were able to effectively cross over into the blood-brain barrier. This is just a schematic of the various barriers to therapeutic delivery into the brain. Primarily what we focus on today is going to be the neurovascular unit, or the access of drugs through the blood-brain barrier into the brain. But once it's in the brain, there are also other barriers that can affect how well drugs work in the brain and how well they distribute. So since we know that there are difficulties with drugs penetrating the blood-brain barrier, there's a lot of work trying to analyze which drugs can penetrate the blood-brain barrier the best. And you can do this by looking at the permeability of certain drugs. And we can map this out by looking at the permeability of the drugs and how well they dissolve in lipids versus how well they pass through the blood-brain barrier. So this is a graph that shows us this, but most importantly, on the x-axis is the log octanol water distribution coefficient. That's essentially a way to describe how well these drugs can dissolve in lipids, because we know that lipids, lipid-soluble materials can pass through the endothelial cells very well. On the y-axis is a measure of how well things pass through the blood-brain barrier. And you can see here from this line here, it's a linear line that, the better lipid-soluble certain materials are, the better uptake or passage to the blood-brain barrier. And as you can see here from a variety of chemotherapy, they're all under the line, which indicates the best permeability of drugs. So most of the chemotherapy drugs that we use are maybe lipid soluble, but not enough to allow for adequate passage through the blood-brain barrier. And so that poses a significant challenge in trying to use some of our chemotherapy to try to treat brain tumors. And so most chemotherapeutic agents are bound to plasma proteins, reducing the free fraction of the drugs in the plasma that is available to cross through the blood-brain barrier. The molecular weights of these drugs are often exceed 400 Daltons, which prevents passive transport, because again, passive transport requires small molecules. Also, the expression of high levels of the drug efflux protein, such as P-glycoprotein, or these ABC transporters, can also remove chemotherapeutic agents from the brain. There are also organic anion transporters and glutathione-dependent multi-drug resistant associated proteins that contribute to the efflux of organic anions from the brain and the CSF. Essentially, other transporters that deliver things out of the brain back into the vasculature that can prevent us from effectively delivering chemotherapy into the brain. Now, we talked about how the blood-tumor barrier exists when in the presence of tumors, and in the presence of tumors, the blood-tumor barrier creates abnormal vasculature, contributing to compromising the tight junctions of the endothelial cells. Drug delivery becomes inconsistent due to distended capillaries with leaky walls and sluggish flow. But you think, if there's leaky walls because of the blood-tumor barrier, there might be higher ability of drugs to pass through the blood-brain barrier. But actually, this leaky tumor vasculature may actually result in a higher drug clearance that extends radially into the normal brain. So the drug doesn't actually stay in the brain very well. It kind of leaks away and it distributes and diffuses out too much for it to be effective. There are studies that have shown that targeting vascular endothelial growth factor, such as using bevacizumab or Avastin, may decrease the interstitial pressure within the brain and result in a greater drug entry into the tumor. And so these are things that are currently being tried to try to make up for the blood-tumor barrier and how it hinders effective delivery of therapeutics. So the last part of the talk, we're going to focus on how do we overcome the blood-brain barrier. Since we understand how the blood-brain barrier works and the components of the blood-brain barrier, and also how it hinders the delivery of therapeutics, there's been a lot of research that's been done on how to overcome these barriers to try to get effective therapeutics into the brain for the treatment of brain tumors. Now, there are multiple ways to think about strategies to deliver therapy across the blood-brain barrier. When we think about the blood-brain barrier, we think about how to bypass the blood-brain barrier. And one way to bypass it, as we talked about, the blood-brain barrier naturally allows for certain types of molecules with certain types of characteristics. So one way to bypass that is to develop drugs that mimic these molecules or mimic these characteristics that may allow them to pass through the blood-brain barrier easily. Another way is to disrupt the blood-brain barrier. Use the molecules that we want to use in their natural state, but disrupt the blood-brain barrier in some way that allows it to be more leaky, and so that these molecules can pass through. A third way of trying to get around the blood-brain barrier is to say, well, let's avoid the blood-brain barrier altogether, because if we can't effectively move things through the blood-brain barrier by manipulating them or by disrupting the blood-brain barrier, can we bypass the blood-brain barrier completely by delivering things or drugs directly into the brain, into the cavities following surgery? And so we'll talk about that strategy as well. So first, we talked about how important drug efflux pumps are in prevention of therapeutics being delivered into the brain. These how these transporters can eject therapeutics from the brain. So there have been studies that shown that maybe we can inhibit some of these efflux pumps. So inhibition of P-glycoprotein, was one of the main ABC transporters, has been shown to increase penetration of temozolomide, a commonly used chemotherapy for glioblastoma, by 1.5 times in mice models. And the idea is that, the efflux transporters emit drugs back into the blood, and if we can inhibit and occupy these transporters, that allows these drugs to be entered into the cells and into the brain. But one of the problems is that when we provide these inhibitors, there's a lack of specificity, because as we talked about, the efflux transporters play a very important role in maintaining the proper status of the brain and pushing out things that can maybe be neurotoxic. And if we provide too many inhibitors for these efflux transporters, then you have things that go into the brain that don't belong there, and then it negates the effect of delivering the chemotherapy. So this idea of lack of specificity is a major problem in trying to target some of these things. And so this could be circumvented with inhibitors with greater specificity, but that's currently being worked on. And it's difficult to do because of the way we deliver these inhibitors from a systemic point of view. But that's one strategy that we can potentially try to increase the amount of drug that we deliver into the brain. Another strategy is modifying the drug. We talked about how certain molecules with certain characteristics are better for delivery into the brain. And so the idea is that, can we modify these drugs to mimic some of those materials that are more friendly for passage through the blood-brain barrier? One is lipophilic analogs. As we talked about before, the blood-brain barrier allows for lipophilic molecules to pass through, which are molecules that are soluble in lipids or fat. So there have been chemotherapy drugs that are formulated into these lipophilic formulations that are more lipid soluble friendly, that can allow for passive uptake into the brain. But one of the problems when you manipulate the solubility of the drugs is that it actually may change how well these drugs perform against the tumor cells. And so this hasn't been shown to be very effective, because we've actually reduced the effectiveness of the drug by trying to make them more soluble in lipids and to allow them to pass through the blood-brain barrier. Another way to manipulate the drugs is using prodrugs. Now, prodrugs are a kind of drug that takes the drug and then manipulates them into an inactive form, or a form or prodrug form, and delivering that prodrug form. The idea is that this prodrug form may be a form that is more friendly for crossing the blood-brain barrier. And then after it's delivered, it requires a modification, and then it moves into an active state. Now, this is great in theory because it allows for improved penetration, but you need a chemical transformation to activate it. So it requires a multi-step process, and it can complicate how well these drugs can go into their active form and how effective they can be. Another strategy of modifying drugs is antibody or gene-directed enzyme prodrug delivery. Now, this idea is that we deliver prodrugs, or inactive form of drugs, and at the same time we deliver enzymes that can activate these drugs. And we deliver them separately so they can enter into the tumor. And then once they're into the tumor, when they get together, these drugs can activate and they can take on the therapeutic effect. This can theoretically allow for enhanced drug activity, but the inconsistency of activating these drugs with the antigen and antibody counteraction within the brain tumor, has allowed the ineffective gene delivery to these tumor cells. And so we're not, because of the extra steps, we're not able to deliver the active drug that we want to for it to be effective against effective in treating brain tumors. And finally, there's vector-mediated drug targeting. We talked about transcytosis of certain types of molecules by binding to certain type of receptors. So vector-mediated drug targeting involves taking drugs and putting them in certain vectors. And these vectors may bind to certain receptors on the surface of the endothelial cells and be transported across the cells. Now, that can be very effective because we're using natural ligand and receptor interactions of the blood-brain barrier, but delivering these vector-mediated drugs can be hindered by the immune response. And so delivering certain types of drugs can lead to immune responses that can destroy the drug, leading to inefficiency of delivering these therapeutics, and so ineffective therapeutics in the end. And so despite these various strategies of drug modifications, there hasn't been a very good way overall to deliver drugs effectively for it to be therapeutic against the tumors. So what's another way other than manipulating the drug? Well, we talked about disrupting the blood-brain barrier and manipulating the blood-brain barrier to make it more permeable or leakier. And so one of these types of strategies is through osmotic disruption of the blood-brain barrier. Now, osmotic disruption is achieved through localized vascular distribution of intraarterial infusion of a hypertonic agent, such as mannitol. Now, essentially what this means is kind of like administering salt or a very highly concentrated solution into the blood vessels. And because you have a very high concentration solution in the blood vessels, it sucks water from the cells out of the cells and into the blood vessels. In essence, the cells shrink because they lose their water concentration. And so you can see here in this diagram, this is a normal blood-brain barrier. These are the endothelial cells. And you can see here, there's very little space in between the endothelial cells because they take up the entire space. And they're closely connected. But if we give an osmotic agent or a highly concentrated solution, it basically sucks the fluid out of the endothelial cells, in essence, shrinking the cells and enlarging the space in between the cells. And this theoretically can allow for certain types of molecules to pass through because there is a greater space in between the cells and allow for greater diffusion of drugs. Now, this has been shown in animal studies to result in a 90-fold increase of drug concentration, which is great. But again, the lack of specificity becomes an issue, as we talked about before. When you give these highly concentrated materials or fluids, you have a global osmotic disruption of the blood-brain barrier, and then you can have too much drug being delivered into the brain, which can hurt the brain and cause neurotoxicity. So the lack of control over how much you allow through the brain becomes an issue, becomes too much. Other ways of disrupting the blood-brain barrier include chemical or genetic suppression. Now, biochemical disruption means using inflammatory responses that can cause a permeability of the blood vessels. This can be seen using bradykinin, which is a peripheral vasodilator, which increases the tight junction permeability by activating bradykinin B2 receptors of the endothelial cells. So essentially manipulates the endothelial cells to allow greater passage of through the tight junctions. This is less invasive and more precise time window than osmotic disruption. But again, in a clinical trial using this type of blood-brain barrier disruption, it was discontinued due to too high of drug levels, resulting in toxicity. So again, the idea of a lack of control over how much drug going from too little to too much becomes an issue. Other ways of disrupting the blood-brain barrier include genetic suppression or antibody-mediated inhibition of tight junction support proteins. Tight junctions are the components in between the cells that create the barrier that doesn't allow for things to pass through in between the endothelial cells. Genetic suppression means we turn down certain types of proteins that are important in formation of tight junctions. So therefore, we have reduced number of tight junctions and increased number of passage of things in between the cells. But again, one of the disadvantages of this type of strategy is the lack of specificity and the danger of having too much passage of drug into the brain, resulting in neurotoxicity. So this theoretically, a disruption of the blood-brain barrier is a good idea, but the lack of control makes it not a perfectly ideal strategy for delivering things to the blood-brain barrier. Now, another way of disrupting the blood-brain barrier involves the use of focused ultrasound. Now, what this is it allows for a localized and a reversible image-guided disruption of the blood-brain barriers. Now, how it works is that microbubbles are delivered into the intravenously into the patient, and they are carried to the tumor. Their focused ultrasonography delivered by MRI or guided by MRI is delivered to the brain. And what it does is it causes these cavitation-generated mechanical stresses to the blood vessel walls. So essentially, the ultrasound shakes the microbubbles up so much that it creates a trauma to the blood-brain barrier, that it creates holes and increased in permeability of the blood-brain barrier. This can result in a consistent vascular leak without tissue damage for from 6 to 24 hours. It's been shown to lead to a 4-fold increase in delivery and penetration of a range of intravenously delivered anti-cancer agents in brain tumors. But one of the issues with this type of disruption of the blood-brain barrier is that if you have too much disruption or too much mechanical stress, because the ultrasonography level is too high, it can result in hemorrhage or edema or stroke or tissue damage. And this can result in neuronal injury due to excessive mechanical activity because of these sonicated bubbles. Now, the way this works is a schematic. You have microbubbles that are delivered intravenously, and then you have chemotherapy that's also delivered. As the microbubbles move up into the brain, ultrasound is delivered to the brain, which causes these microbubbles to shake and to disrupt the blood-brain barrier. You can see here, this is the blood-brain barrier. The microbubbles, because they're oscillating as a result of the ultrasound, creates leaks in the blood-brain barrier, which allows for the chemotherapy to pass through. So it's kind of a combined approach where on one hand, we deliver a disruption of the blood-brain barrier and at the same time deliver the chemotherapy to allow it to go through for a transient period of time. And that transient period of time is very important because, as we talked about, one of the barriers of the other strategies is that we can't control how long the blood-brain barrier is down. But this, we know only the blood-brain barrier is only down for about 6 to 24 hours. So it doesn't allow for too much chemotherapy to pass through. And it doesn't allow for other toxins to pass through because the blood-brain barrier is restored in a certain amount of time. There are certain types of devices that can deliver a focused ultrasound in this method. It started out using an external ultrasound transducer, which we placed on top of the skull, and it created ultrasound that resulted in leaking of the blood-brain barrier. This has evolved to a larger device, which has multiple areas which can deliver ultrasonic activity to allow for various areas to disrupt the blood-brain barrier. There's also another type of focused ultrasound device which is implanted underneath the scalp, and there is a single device that can be delivered in one area, or multiple devices that can be implanted at the same time. So that allows for greater coverage of disruption of the blood-brain barrier. And there are several types of clinical trials, both some in the United States, some in Asia, and some in Europe, that are testing these out. A lot of them are the preliminary period where they're trying to understand the right amount of disruption and to not allow for brain tissue death, but allow for just enough blood-brain barrier disruption to allow for the entry of therapeutics. Also, another way to disrupt the blood-brain barrier is hyperthermia-induced blood-brain barrier disruption, and this includes heating the head up to 42 degrees Celsius for 30 minutes. And this has been shown to allow for increased uptake of certain types of chemotherapy in mice models. Now, outside of disrupting the blood-brain barrier or manipulating drugs to get through the blood-brain barrier, is bypassing the blood-brain barrier altogether. And this is a area that has a lot of research in, because this says, let's forget the blood-brain barrier. It's too hard to manipulate it and control it in a way for us to safely deliver therapeutics. We have to go around it. And this involves directly injecting chemotherapy into the tumor. Some of the challenges include the diffusion gradients, how much chemotherapy you get into the tumor, where it goes to, and the way the tumor is structured, and whether you can get enough chemotherapy in a big enough area for it to be effective. One of these types of direct administration of chemotherapy are implanted polymers. And these are essentially drug implanted wafers, which are placed into the brain cavity following tumor resection. The most well-known implanted polymer, of course, is gliadel, which is a carmustine-loaded biodegradable polymer wafer that was developed by Dr. Bren. And how this works is that after resection of the tumor, you place these polymers into the brain cavity, and over a period of time, these polymers slowly dissolve and distribute the chemotherapy into the cavity. The initial trials of these polymers demonstrated an increase in the mean survival time of these patients with current gliomas who received gliadel wafers. But one of the issues is that, as you can see here, the wafers are only on the surface, on one surface of the cavity. So there is a very high concentration of the drug in a localized area. And so sometimes that leads to a high risk of local neurotoxicity. And then it results in poor wound healing as well. And one of the challenges with this type of delivery and any kind of direct delivery is we want the drug to go past the brain, go further out into the brain, and we can't control how well the drug diffuses out into the brain. And so that's one of the main limitations of using gliadel, is that we can't control how well the chemotherapy goes out into the further parts of the brain past the actual resection cavity. Now, to get around that, there's been direct delivery systems into the cavity. This essentially includes drug delivery through an access port under the scalp. And this can be ports or access ports into the brain tumors or into the ventricular system. This allows for direct delivery of intermittent boluses of injections of anti-cancer drugs directly to the tumor or the cavity. This can be effective because it allows for bypassing of the blood-brain barrier, but it can be limited by infections or catheter obstructions and inadequate drug distribution again, because if you deliver a drug through a catheter at a passive rate, the drug may or may not diffuse out into the entire tumor or diffuse out past the area where it's being distributed, and it may cause a collection locally in a certain area, which may lead to neurotoxicity. So one of the ways to get around this collection of lack of distribution of the drug is a strategy called convection enhanced delivery. Now, this is essentially a catheter delivering drug, but it's done so under continuous infusion under positive pressure, which means the drug is constantly being pushed. So the drug is being pushed out, so it makes it diffuse further and further out away from the site of where the tip of the catheter is. This is based on a bulk flow mechanism. It's created by a pressure gradient from a pump that pushes the solute through the catheter, and that's targeted within the brain. One of the advantages of this positive pressure application of drug is that it bypasses the blood-brain barrier. It's driven by pressure, so it enhances the distribution compared to diffusion limited delivery. And it lacks a local neurotoxicity because it pushes the drug out and diffuses it out into the brain. But one of the disadvantages is that if the catheter is not big enough or the drug does not diffuse well enough, you can have backflow of the solute because you're not pushing the solute with high enough pressure for it to dissolve into the brain. And also, if you only have one catheter, you can have a lack of proper distribution into multiple areas of the brain, and so your coverage is not quite as good. One of the ways to circumvent this is multiple different people have come up with different types of catheters. One of the catheters actually was invented by a colleague of mine at the Moffitt Cancer Center. Is termed the Cleveland multi-port ventricular catheter. And this was invented when he was in Cleveland. That's why it's called the Cleveland catheter. And so this catheter is meant to be placed into the brain. And it's unique because after placing the catheter into the brain, it has 4 smaller catheters that can be extended out into different directions. And so these 4 catheters are very small. So, and drug is pushed at a very, very high concentration, high pressure. So it allows for a better distribution and coverage of the drug once it's distributed into the brain. And so this tries to circumvent some of the disadvantages previous catheters have had when applying convection enhanced delivery. And in a first human trial using the catheter, it demonstrated that this catheter can provide a very broad distribution of the drug. Here, drug is provided and it's mixed in with contrast, so you can see it light up in the brain. And so essentially, the part that lights up matches the distribution of the drug. And so this is the test to confirm that the catheter allows for a high distribution of drug into the brain and allows it to diffuse out and not collect up in a certain area. And currently, actually, at Moffitt, we have a clinical trial using this catheter to try to deliver chemotherapy to the tumor as well as to the surrounding tissue. And this is a 2-part clinical trial in which we deliver, using the Cleveland catheter, deliver chemotherapy into the tumor. We resect the tumor, and then we deliver chemotherapy around the tumor to try to attack some of the invading brain cells, invading tumor cells in the adjacent brain. And this is an example of one of those types of trials, is that you had a recurrent glioblastoma brain tumor here, and following resection of the tumor, we implanted the catheter, and you can see here, the part that lights up here is the drug that was administered, and you can see how it diffused out a little bit more than collected a certain area. So this is to try to test to see if we can probably distribute the drug in an effective way and bypass the blood-brain barrier. This clinical trial is open at Moffitt and is also, I think, about to be open in Ohio State University in Columbus, Ohio soon. So in summary of our second part of our talk, the blood-brain barrier plays an integral role in allowing metastatic cells to cross into the brain and develop tumors. There are many strategies that have been attempted to circumvent this blood-brain barrier to allow for more efficient delivery of therapeutics to brain tumors. These include manipulating the drugs to allow for better passage across the endothelial cells, as well as drug delivery while translating, disrupting the blood-brain barrier to allow for greater permeability. But obviously, these strategies are hindered by certain mechanisms that can result in high levels of neurotoxicity. One of the strategies to circumvent this is the direct delivery of therapeutics to brain tumors, such as using convection-enhanced delivery, which allows for direct delivery of therapeutics by bypassing the blood-brain barrier. And with that, I will conclude and take any questions.
Thank you so much, Dr. Liu. We will now take questions. As a reminder, if you do have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. So one of the first questions we have here is asking about standard therapies when it comes to glioblastoma, like Temodar and Avastin. Can you talk about some of the limitations that these therapies have and what studies or what is currently being done to help these treatments better penetrate the blood-brain barrier?
Yeah, so Temodar is kind of our classic first-line therapy. It's kind of the standard of care, and Avastin is commonly used as a second-line therapy for recurrent tumors. There have been some studies that try to use some of the techniques that we talked about, this focused ultrasound, to open up the blood-brain barrier while delivering Temodar at the same time to see if indeed it allows for a greater concentration of some of these drugs into the brain. And so there have been studies that have done that. None have been conclusive as yet, but there's some ongoing studies in that list of clinical trials that I mentioned. This is primarily for Temodar. Avastin actually is a very unique drug because it actually targets some of the structures that are involved in the development and the maintenance of blood vessels. And so actually it manipulates the blood-brain barrier in certain ways that have allowed greater penetration of certain types of drugs and restoration of the blood-brain barrier despite the presence of glioblastoma. But despite this, unfortunately, Avastin hasn't shown a clear survival benefit, although it's shown that it can keep tumors, from progressing on MRI scans. And so current work is still being done to try to understand how avastin interacts with the blood-brain barrier exactly, and how we can use its interaction with these endothelial cells to better deliver chemotherapy. And so I think current work is still being performed to try to understand how these interact, how the blood-brain barrier can be manipulated precisely for these drugs.
Thank you so much for sharing that. In your presentation, you also talked about how tumors can disrupt the blood-brain barrier, and also some techniques to disrupt the blood-brain barrier to allow for better ability of the treatment to travel to the brain. Is this disruption permanent? Does the blood-brain barrier repair itself? And can it cause any long-term effects in patients?
Yeah, that's a great question. And so that's one of the main differences in the different types of strategies. As we talked about the osmotic disruption, in which we give the very high concentration of fluid to try to suck fluid out of the cells. Those are typically, most disruptions of blood-brain barriers are typically transient, but some are less controllable. Some, like the osmotic disruption, the biochemical disruptions using inflammatory mediators to disrupt the blood-brain barrier, we're less able to control exactly how long the blood-brain barrier is down for, which means it's open for other things to pass through and higher risk side effects and neurotoxicities. And that's one of the advantages of focused ultrasound, because we know from studies that it only disrupts the blood-brain barrier for about 6 to 24 hours. And so we know the blood-brain barrier will be restored and it's closed down, so it doesn't allow other toxins to get through. The other advantage of focused ultrasound is that it's focused. It's directed at a very specific spot within the brain. So you can direct only the ultrasound at the tumor. So you don't disrupt the blood-brain barrier at other spots in the brain. And so specificity is one of the common themes here, is as in one of the things that kind of prevent us from improving our therapeutics. And using focused ultrasound to only break down the blood-brain barrier within the tumors can be very effective. But overall, the blood-brain barrier is not permanently damaged in any of these techniques. It's really a question of lack of control into exactly how much it's being broken down.
Thank you so much for explaining that in such a thorough way. Let's see. So you talked about the focused ultrasound. Is this used only to allow for the penetration of chemotherapy drugs, or is it also used to allow for better penetration of other drugs as well?
Well, primarily it's used in the oncology setting for penetration of chemotherapy, and that's kind of one of the main clinical trials being used for. Initially, focused ultrasound was developed for ablative reasons, to damage brain in certain types of neurosurgery procedures in which we need to damage lesions. It's also been tried for treating the brain tumors themselves. When the ultrasonography is turned out at a very high level and causes a significant disruption of the brain, it can actually destroy brain cells. And that's actually obviously one of the side effects of the focused ultrasound. And so we obviously don't want to use it for that, because the control is not very good. And so we've reserved, the current studies have reserved focused ultrasound at a lower level, primarily for the distribution of increased penetration of drugs.
Thank you so much. I think we have time for just one last question. Can you touch on Optune and how the blood-brain barrier might impact the use of Optune?
Yeah, Optune uses a different mechanism for trying to prevent the division of cells. It creates a magnetic field in which it disrupts how the tumor cells are dividing. So to prevent them from dividing rapidly and in essence, and then, prevent tumor growth. And that doesn't really disrupt the blood-brain barrier. And so it's really a different mechanism preventing cell growth. It doesn't affect how chemotherapeutics get into the brain. And so it's a different pathway, and I don't think they intersect.
Thank you so much for your time in answering these questions. Unfortunately, that is all the time that we have for today. Thank you again, Dr. Liu, for taking the time to share your insight and expertise. And a special thank you to each and every one of you for joining us online today and sharing your questions. I know we have a lot of questions that we weren't able to address. Dr. Lu, if you do have a few more minutes and you have the time, I encourage you to maybe just skim through some of the questions and type some responses as your time allows. We
Sure.
hope that each of you found this webinar to be beneficial. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit the ABTA website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282.